Hello everyone, my name is Video-Espanola and I am a graduate student in the Speech Language Pathology program at Seton Hall University, alongside with my partner Laura Guempel, who is also a student in the same program. Today we will be presenting our critically appraised topic review on cross-linguistic generalization in bilingual adults with aphasia. So for our research, this was the background. So up to 60% of the world's population is bilingual or multilingual, which means that having bilingual or multilingual patients with aphasia is not uncommon. However, the problem that presents itself is that there is a gap in the literature addressing bilingual adults with aphasia. So, an important investigation for this population is determining whether traditional naming treatment in one language leads to cross-linguistic generalizations on naming tasks in another. So the purpose of this project is to present a critically appraised topic review on whether traditional naming treatment in one language leads to cross-linguistic generalizations via naming tasks, which leads to our outcome of interest being naming tasks. Our research question is, for bilingual adults with aphasia, does traditional naming treatment in one language lead to increased cross-linguistic generalizations on naming tasks? So for our PICO elements, our population is bilingual adults with aphasia. Our intervention is traditional naming treatments, usually semantic. There was nothing to compare our treatment to, and our outcomes were increased cross-linguistic generalizations on naming tasks. So for our literature search, you can see here, which is table 2 from our poster, our initial search terms for each database. So the database search that we did was only on PubMed, and our search terms included aphasia and naming and bilingual therapy or cross-linguistic therapy. And an additional limitation that we had added was that it could only be within 10 years, so that we would include the most recent information and most recent research. So our time limit was only from 2009 to 2020, and we had completed this project in 2020. Our inclusion criteria was that articles had to be written in English, the full text was accessible, the population of bilingual adults was with aphasia, and outcomes were measured with a naming task. On the right side of this slide, you can see various exclusion criteria that we had. So we did not include anyone with multilingual intervention because we were only looking specifically at L1 and L2. We did not want focus on a specific type of intervention or strategy or on difference in brain structure or activity. We were looking solely at the effects of aphasia. And we did not want a focus on a medical profession other than SLP because this is SLP-based research. And we were looking for articles that had sufficient discussion of results. So if there was no good results or discussion session, we did not include it. As you can see here in figure 1, we can see our Prisma chart, which depicts the flow of information. So in our initial search, we had 93 articles total with 0 duplicates, and we ended up excluding 81 articles for irrelevance in populations, disorder, intervention, and medical professions involved other than SLPs. So essentially our exclusion criteria. In our eligibility search, we ended up with 12 articles, but we ended up excluding 9 due to the lack of information in the discussion section, the use of multilingual populations, and irrelevant outcome measures. So we then included 3 articles that met the best available evidence for this CAT. On this slide, you can see the patient characteristics for the articles that we included in this CAT. So for the first article, which was Croft and others from 2010, there were 5 premorbidly right-handed participants with aphasia who were bilingual in Bengali and English. Etiologies included a left hemisphere stroke, a hemorrhage in the left internal capsule, a left thalamic hemorrhage, 1 intraventricular hemorrhage, and a left parietal hematoma. There were 3 females and 2 males, and ages ranged from 17 to 52. All patients, according to this article, had anomia. In Curlin and others from 2011, it was a single subject design with one 65-year-old right-handed female with aphasia who was bilingual in Spanish and English. She was 14 months post-onset with her lesion in the cortex. Auditory comprehension was significantly better in L1. However, prior to the stroke, L2 writing and reading skills were good. In Kieran and others from 2013, 17 participants with aphasia, where the handedness was not provided or clear in the articles, were bilingual in Spanish and English. All participants were at least 5 months post-onset from a left perisylvan area stroke, except 1 who had sustained a gunshot wound in the head. There were 11 females and 6 males, and their ages ranged from 33 to 87. On this slide, you can see the dosage of treatment for these articles that was provided. So for Croft and others, they had 10 sessions that were 2 hours long over 5 weeks, so about 20 hours per participant. For Curlin and others, they had 10 sessions for 2.5 hours over 2 weeks, so they had 25 hours of treatment. For Kieran and others, they had 2 sessions a week for 2 hours over 7 to 13 weeks, between 28 to 52 hours. For Kieran, the weeks of treatment depended on accuracy, so treatment ended when accuracy reached 80% on naming items across 2 consecutive sessions. On average, 13.67 sessions were completed over the course of 5.83 weeks for these studies. This results in a total of 25.67 hours of treatment across all of these studies. Okay, I will be now letting Laura Guempel present on the rest of this presentation.
Hi everyone, as Angelique introduced in the beginning, my name is Laura Guempel, and I'll be presenting the summary of our article results as well as conclusions and clinical recommendations following the research. So in summary of our articles, the Croft et al. Article involved naming therapy in both English and Bengali in 2 separate phases. The treatment consisted of 4 groups of words used in both semantic and phonological treatment interventions. Half of each therapy session was used for semantic treatment and the other half was used for phonological treatment. The outcomes were measured on a picture naming task involving both treated and untreated items in both languages, and the effect sizes from this article were not calculable. For the Kurland et al. Article, there were 3 phases of naming intervention for a single subject, conducted 2 months apart. So phase 1 was conducted first in Spanish only, followed by a 2-month period for washout of intervention. Then there was phase 2 conducted in English only, followed by a 2-month washout period. And finally, phase 3 was conducted in both Spanish and English. Intervention for this article involved massed or intensive verbal practice in naming, using traditional therapy tasks such as reading names, semantic cloze tasks, and all involved 6 sets of 16 line drawings. So the outcome for this article was also picture naming task with treated and untreated items for both languages, and the effect size was also not calculable. For the final article, Kieran et al., treatment was provided in 1 language. There were 8 participants receiving treatment in Spanish and 9 participants receiving treatment in English. And participants were given 3 sets of stimuli, each set in both English and Spanish for the outcome measure. So the outcome measure was also a picture naming task, and the outcome measure was using treated and untreated treated and untreated items in both languages, even though treatment was provided in only 1 language. So the effect sizes for the untrained items within language was -5.0 to 5.0, showing improvement from baseline for some, but not all participants. And the effect sizes for generalization to untrained items between languages ranged between 4.0 to 10.0, with 4.0 showing minimal improvement and 10.0 showing significant improvement. In discussion of conclusions from these 3 articles, there's 3 main takeaway points. First, participants had slightly increased naming abilities when treatment was provided by the clinician in the participant's stronger language. So the Kurland and Kieran articles both showed that there was more improvement when the therapy was provided in this patient's stronger language. In other words, if the clinician was speaking the patient's first language in their therapy session. The Croft articles showed about the same amount of improvement regardless of the language of intervention. However, Kurland and Kieran did both show greater increase in naming abilities when the therapy was provided by the clinician in the patient's stronger language. The second point is that semantic therapy was shown effective as a naming treatment for these participants in all 3 studies. So some studies used both phonological and semantic interventions, but across all 3 articles, semantic interventions were shown to be effective for naming treatments in this population for bilingual people with aphasia. The third point is that cross-linguistic generalization varied across participants and studies, but generally greater generalization or improvement was seen in the patient's stronger language, again, regardless of either the intervention, slightly more when the intervention was provided in the stronger language. So this cross-linguistic generalization did vary across articles. It was also important to note that in 2 of the 3 articles, they specifically mentioned that both of the patients' languages did improve with treatment, just reinforcing the idea that this semantic and lexical networks are still yet to be fully understood in the patient's brains and in the effectiveness of treatment across languages. So the big main takeaways are that patients did show increased naming abilities when therapy was provided in their stronger language, that semantic therapy was shown to be effective for treatment of this population, and that cross-linguistic generalization varied across participants, but general improvements were seen more so in the patient's stronger language. The clinical recommendations based in these 3 articles. Based on the findings from these articles, traditional semantic naming therapy is recommended for bilingual people with aphasia, and the language of therapy is slightly beneficial but not exceedingly significant as mentioned before. If therapy is able to be provided in the patient's first language, there was some additional improvement shown for these patients if it was in their first language, but improvement was shown overall when both languages benefited during therapy provided in either and or both languages. It is important to note the limitations of the research. Articles in this research consisted of single subject research designs or case series. Future research would be beneficial to have randomized control trials being the best level of evidence for this research question would show even more effectiveness of this intervention. And research should include a large randomized sample with participants having the same language 1 and language 2 if possible, and use one naming strategy with one valid and reliable measure of outcome as the specific interventions and measures of outcome did vary slightly between these studies. So thank you very much for your time. We appreciate you participating in this research and watching our presentation, and we wish you all the best in your interventions and research for your bilingual patients with aphasia. Thank you very much.